Thank you very much, Ty. Yes, this feels like a family with Perfusion.com, and we get to come back and see all of our friends at these meetings, so it's a lot of fun. And like Ty said, I did send out a survey back in November, and so a lot of you might have been able to have participated in this survey, and I really appreciated it because we wanted to see, as a traveler, I wanted to see how everybody else was doing it compared to what I saw as a traveler also. Some of my disclosures: I am on the Sanibel Symposium Board of Directors, and I do subcontract with Perfusion.com as a traveler, and I'm also a very proud AmSECT member and a proud member of Perfusion.com also. Some of the objectives for this talk this morning or this afternoon: I'm going to discuss the blood management survey results that we did. I want to discuss and compare with the STS blood conservation guidelines and compare what I've seen over the country and what we do and what you do also with the AmSECT standards and guidelines for perfusion practice and just the standard 13 for blood management in particular. And then also review some of the AABB national statistics, and then identify some cost analysts and case study stats, and then a few take-home messages for you to be able to maybe adapt in your practices at home also. So I want to show this pictorial. Einstein said it just so very well. Change is good. Insanity, doing the same thing over and over again and trying to expect different results. Now, have you ever went to a program or started with a program and they always said, and you kind of wonder, I wonder why you guys did it that way? And they said, well, you know, I don't know, that's just the way everybody else did. We've always done it like that, you know, so we've never changed. So I see that, and just with the many years that I've practiced, it seems I try to think, how could I do this better? And I've done this for perfusion for probably over 35 years now, and I'm still learning. I'm still learning how to do things and how other people do it, and maybe to make my practice a little bit better, a little bit smoother. I was visiting with a student here recently and kind of asking them what they would like to see themselves in 5 to 10 years or so. And they said, it's kind of funny, he says, well, I want to go to someplace that's maybe work for about 5 or 7 years and learn everything I need to know, and then be able to, you know, adapt that practice and maybe do something solo or whatever. And I said, I kind of go, 5 or 7 years, yeah, you could probably get a really good practice started and, you know, have a really good, develop a really good strategy and stuff. But I go, you know, I've been doing this for many, many years, probably more, you know, and I still learn. Every time I go someplace, I learn something new every day. That's why I love this field. So like I said, I'm a traveler right now, and I call myself kind of a rental perfusionist. I really enjoy this. I get to see all kinds of different hospitals and meet different friends, and the way they do that, and different protocols and all too. So it's been really fun. And then I've surveyed with this study several perfusionists over the country. So how can I kind of take away from this? If it doesn't challenge you, it doesn't change you. So I really want to have you guys think how you do your practice at home and how you could maybe do things to change. Now, these are some that I've developed 15 different questions, and I say I developed them. I kind of kidded on that one. I had many, many people help me, and Ty was one of them, and most of the people from Perfusion.com and a lot of AmSECT members also helped me devise these questions to fit our practice today, or how it should be practices. But the first question was, how does your cardiac team, perfusionist, anesthesiologist, surgeon, handle fluid management strategies? And most of them, we did have about 500 results, or 500 people that helped with this survey. And so kind of wanted to see kind of what everybody did. And most of them reviewed with the anesthesia, surgeons, and that sort of thing. Kind of wanted to see how many people actually participate in your timeout before the surgery starts. I know it's a joint commission, everybody should participate in the timeout, but do you guys make sure that you're in the room, come back from your break, your whatever you need to do to make sure you are participating in the timeout? I think that's very important to be able to do that. and to be able to talk with your surgeon, anesthesia. Sometimes the surgeons just let the perfusionists kind of do their own thing in their protocols and all, but I think you have come up with a better idea if you do this with a multidisciplinary action and maybe talk it over with your teammates to see how you want to go and make it best patient care. How do you as a perfusionist handle fluid management? And I said that you could choose more than one answer on this also. Most of them did a chart review and utilized the priming protocols and utilized the institutional target hematocrit. Some of them also added that they used a hemoconcentrator on all cases, or some of them, or PRN. And Al Stammers yesterday kind of reminded us, using a hemoconcentrator might have some AKI with the hemoconcentration. So maybe we need to review those articles again and start thinking about that a little bit more also. And they also, the STS guidelines also say that maybe should use mini prime circuits also is one of our things that we should probably either mini prime or at least reduce our prime, and then wrap and maybe ANH also. And as I am talking, kind of think of some of your strategies at home, what you do to decrease your prime and do a little bit better patient care. Now, does your team use EPO or ProKit during cardiac surgery? Most of our people said no, but and some of them said only on Jehovah's Witness patients they utilize this. But as we were talking yesterday also, if we just do certain things on our Jehovah's Witness patients, why couldn't we adapt those changes and those protocols to all of our patients? If you're treating your family members, would you treat them a little bit differently? Would you do blood management a little bit differently also? Some people think that, maybe they're not utilizing EPO or ProKit because it's a little bit, expensive, and then they have to use it several days in advance before surgery. And sometimes we don't have all that time to be able to adapt to that with our unscheduled patients. How about point-of-care instruments? How do you use point-of-care management to manage your anticoagulation during cardiopulmonary support? And also you can choose more than one answer on this too. Some of them use the ISTAT or the EPOC, which measures the hematocrit with the conductivity also. And Colleen and Gerald Myers described the difference of these very eloquently yesterday. But most of them use the Medtronic HMS and the Hemocron also. Now, do you use ANH or sequestration protocols? Or how about the one that Ty described earlier on Wednesday? Most of them said no on the sequestration or the ANH. And, we used to do ANH, I used to call it in the olden days, but we kind of got away from that a lot. But maybe it's something that we might want to think about again using. What strategies do you use for residual pump at the end of each case on your bypass cases? And I said you can choose more than one answer for this also. Most of them sent all the pump blood to the cell saver and then give back to the patient. And then some of them gave all the pump blood back to the patient prior to decannulation. So we tried to sneak it in there before we send it over to the cell saver to save the products. And some of them also bagged the residual blood volume and gave the anesthesia, and then gave additional protamine, 50 milligrams of protamine following that too. Do you prime with Amicar or Tranexamic Acid, or add it to your pump volume later in the procedure? Most of them primed their pump with Amicar, or anesthesia gave it also. And there's other ways that people mentioned that they gave the Amicar or Tranexamic Acid also, only maybe on Uzi patients that they needed it for, or even after the aortic cross clamp was off. Do you use pump suckers during bypass or during CABG procedures? And if so, do you send it back to the cardiotomy instead of diverting it to the cell saver? And most of them said that they did go back to the cardiotomy instead of diverting it to the cell saver. Now, there's been a lot of discussion on this over the years, and it's kind of 50-50 on what you people do. Has anybody tried the Levanova with the Inspire dual cardiotomy? Anybody have been able to change or utilize that yet? Where they have the cardiotomy, separate cardiotomy, where you can put the suction into that portion of the cardiotomy and save it for later use if you want to put it into your pump. Or a lot of people are using it for or when they're started the protamine, they can still use a sucker, because a lot of practices have protamine. You stop the suckers at 50% in or 10% in, or that's all over the board sometimes on the protocols. But this new Inspire is kind of nice to be able to suck it into the cardiotomy and then just keep it and then utilize it if you need to later on. But suction blood, as we all know, is damaged, and it contains a lot of the fat emboli and tissue debris and has a lot of inflammatory response mediators in there. But somehow, that can cause potentially neurological dysfunction. But somehow our brain seems to accept that, and our body kind of tolerates that damage. So there's still a lot of research that could be done for this in this area. What do you utilize as your trigger for transfusion during bypass support? I remember years ago when I first started out, we always used a 10-30 method no matter what. If you needed, if you were, 30% or less, you'd give 2 units. That's kind of standard and all. But, we've come a long way since then, thank goodness. But and this is kind of all over the place also. But as you can see from this week, where a lot of our great speakers were here, you need to treat the patient as we've been taught and stuff, and instead of the number. I think Ty's has been speaking on this for a long time. But I think that's very, very important for us to do that. Just instead of treating the number, treat the patient. What clinical values do you review prior to cardiac procedures? Now, most of them all did the H&H, PT, PTT, platelet count, the INR, and did a baseline TEG, maybe about a third of them. But one respondent said, if you have it, use it. Of course, just always identify your laboratory test, whatever you can do. Which analyzer do you use for your platelet function information? 182 of them use the TEG. Then a few of them use the Rotem. Many of them didn't know what the main lab did their tests, or what they did, or if they did them even routinely. So this is kind of an interesting question. And some of them, of course, wanted to use a TEG in the future. What preoperative identifications for high-risk patients are you reviewing to make your transfusion decisions? And you could select more than one answer on this also. Most of them advanced age, if they're anemic or not, small body size, preoperative antithrombic drugs, coagulation abnormalities in the patient, comorbidities, and not so much as the male or female. Kind of funny too, when I was years ago too, whenever a woman was came in to have a CABG or aortic valve or something, one of our surgeons, said, "Well, go ahead and prime the pump with 2 units of blood," because, and I said, he said, "Well, it's a woman, and all women get blood, period." So that's kind of like we've come a long way. So our goal should be no transfusion. Does your hospital have a blood management team? And does Perfusion participate? And this is really interesting. I got a lot of respondents on this that said that they would like to start a blood management team, but nobody else is interested in, or how could I start? So there's a lot of information for this, and we'll kind of talk about this a little bit later on. But, and one of them said, no, but they review all this information through our STS data. Does your cardiac team routinely administer blood bank prior to surgery to keep the STS transfusion stats low? And when somebody suggested to have this question on here, I thought, boy, that's pretty sad that they would have to do that. But they want to make their, some people are, they want to make their numbers good. So if they don't, they get a ding, if they show that they're below everybody else's numbers. But somebody had responded to, if they did it, that would be criminal and unethical. And do you do things differently for Jehovah's Witness? And 311 of them said yes, that they would. So, I think that we should all treat all of our patients like they're Jehovah's Witness, and not necessarily a Jehovah's Witness, but they should really treat your patients very, to give, their goal should be to give no blood if possible. So that was my last question on our survey, which I want to show some of our comparative studies with the SABM and the ABBB and the STS guidelines also, and AmSECT also. But SABM's definition of the patient blood management is a timely application of evidence-based medical and surgical concepts designed to maintain hemoglobin concentration, optimize hemostasis, and minimize blood loss in an effort to improve patient outcome. And I think that's most everybody's definition of blood management. So if you have a patient blood management team at your facility, you could improve your patient outcomes with your best outcome, with your patient, with a lot of information that's been guided for us, which would lower our patient's risk and then reduce the costs also. Now there's kind of for a patient blood management program, it's a team approach, and if you can think of anybody else, it would not only start with the OR, the surgical team, but also it should encompass multimodality team of collaborative effort with the preoperative group, an intraoperative group, and a postoperative also. And I kind of listed a few people in here, but if you could think of anybody else that you might add to this group of people for this collaboration effort also. Perhaps people in the blood bank I think would be very helpful also. But some of from the SABM with their patient blood management programs with their administration and clinical essentials, this groundwork has already been done to start a blood management program. And you need to find a champion in your group. And it could be, why not perfusionist? Why not a perfusionist be the director, your champion for your blood management program? Some of them have, people from the blood bank or from your surgeon, your lead surgeon as a champion, but why couldn't you, as a perfusionist, be this champion also? So their blood management programs, why not hospital embrace a blood conservation culture? Now you can see these different things that have been listed with a collaborative effort, but if you could show that your hospital, that you could reduce their hospital costs, improve their patient care with their best practices in their hospital, I think your hospital would show that they'd be on the cutting edge. Now, I mentioned before earlier, if it doesn't challenge you, it doesn't change you, right? So now I want to kind of go into the STS 2011 guidelines to see if you could or would or even should change your practice to make it better. Now, much has changed before these guidelines were developed back in 2007. They've been reviewed and revised on their recommendations, and this article has been highlighted some of the changes that are a great interest to perfusionists also. And we do have perfusionists that helped write these clinical guidelines. And I'm just going to kind of review a little bit of them that just pertain to perfusion. Kind of in review, I want to kind of go over the classifications and the levels of evidence that we show. And so if you see like the class 1, there is evidence on this. Class 2 that should be probably performed. Class 2A is additional studies might be needed. And then class 2B, broad objectives are needed. And class 3 should be performed, but they might, or should not be performed, I'm sorry, and they just might be harmful also. Now that's the classifications. These are level evidence. So if you have a level A, they're for multiple randomized trials. So if you have a classification 1 with a level A, those are very important ones that we should be following. So this first one is the blood conservation interventions that the STS guidelines have showed us in the revisions in 2011. They had mentioned microplegia, and we'd gone over that quite a bit in our seminar this time. Vacuum assist. And the class 1 was, and level A was the mini circuits. Now that could be mini circuits, or that could also just be made your circuit very small and decreased your prime quite a bit also. And then the modified ultrafiltration was a class 1 level A also. Some of the other on the blood conservation interventions was the biocompatible cardiopulmonary bypass circuits. I think most of us probably do utilize those. Blood management team, class 2 level B. So this is something that maybe you should get going in your facility also. And possible EPO if you're not already. And this is something that maybe you should ask, your hospital, your surgeons, your partners, what if they are utilizing this or not. And then, of course, tranexamic acid to reduce the total blood loss. Now, these are just the preoperative interventions that are recommended to identify the high-risk patients, the ones with the multiple comorbidities, in which we showed on the survey that I did that they are identifying them with advanced stage, preoperative anemia, small body size, and that sort of thing too, any coagulation abnormalities and that sort. And then these are the transfusion triggers also, and we had talked about them multiple times too this week, so that's been really, really nice to be able to show these recommendations also that, that we're doing a good job at this. And then blood salvage interventions. Once again, the autotransfusion is a class A, recommendation A, and level of evidence is A also. So once again, there's no definitive answer for the cardiotomy suction damage and the no wash or the sequestration wash. We still need to do some studies on this to make sure that we are doing this properly, and because we do know that we need to be washing out the lipid emboli, and that sort of thing to decrease the inflammation cytokines. And then recommendations from previously published guidelines for perfusion intervention. And these are still more classifications. The open venous reservoir, class 2, level C. Protamine, 50% of our total heparin dose. We kind of talked about that a little bit this morning with Dr. Bader, but so maybe we're using too much protamine. And then, of course, the RAP and the ANH also. They did mention, I just briefly touch on the bypass times. If you know if they're going to do a longer procedure, 2.5 hours or so, maybe you should start with a higher heparin concentration during bypass. And then they're saying that another recommendation, which is a recommendation A, class or level A, classification 1, is a multidiscipline approach by bringing in everybody into this to see how you should be able to do the blood management also. And then if we want to bring in the AmSECT standards and guidelines too, just the blood management portion. In 2011, during my reign as AmSECT president, we requested that the ICEBP subcommittee review our standard guidelines and essentials. And in 2013, the revision was completed and adopted by our membership. And these guidelines are continually reviewed and updated. And there's some recent results that they've been updated and have another vote on for them this month also. But the ones that pertain mainly to the blood management is to that they should, blood management efforts should include the following, which is a timeout. So I think this is on our talk on the study on the survey also to see if they were participating in the timeouts, which most of them were. But this is a good time to be able to do your calculations and show what your hematocrit will be on, going on bypass, and kind of talk to your surgeon and your anesthesia to say, hey, this is my calculated crit going on pump. What do you think we should be doing? What are your recommendations? That sort of thing. Kind of tell them what your plan of action you might recommend also. It's kind of interesting, the more the anesthesia, usually the surgeon, they usually let the perfusion and anesthesia make that decision, usually when I'm in my travels and stuff. And then depends on which anesthesia person that you're working with, whether they would like to give blood or not. So it's all over the place too. So if you can kind of give them your recommendation, they usually will go by your recommendation if you have something, evidence to prove to them why you're making that determination. But we've been doing a really great job, I think, of minimizing our circuits and decreasing our pump volume. I think years ago we used to dump in 2 liters in our prime and go with that, but now we're really doing a great job of decreasing our tubing size, and I think we're doing a great job on that. And there's always continued information that we need to do. And then this is the standard was to calculate and communicate to the surgical team prior to going on bypass what your hemoglobin hematocrit might be, and share this with them and make a team decision. Now this is a study done by Dr. Hannon, and it's kind of an old articles back in 2007, but most of the overlying principles still apply to us too. So and we kind of discussed about this already, but this is just a kind of a good review, so that the transfusion risks are increased for these pneumonia, ICU stay, ventilator time, infections, and mortality. So some things you should think about before transfusing a patient, and this is on the AABB recommendations also. The transfusion should only be given on the first laboratory value, and I kind of didn't really understand what they were meaning by that. But they're just trying to tell us not to do several different blood draws to examine this patient. Sometimes you can come into you'll see their first H&H coming into the hospital is 40. And by the time they come down to us down in surgery, they're 32. And you think, how did it get from 40 to 32? And then right before we go on pump, it's down to 28 or 26. You think, but then you see sometimes anesthesia, just really dripping in a lot of volume. And you kind of question that, and they said, well, our patient was really dry when they came into the room. So it's kind of still a work in progress, trying to work with anesthesia and the cath lab people too. So if we could just be more vigilant at this, I think it would be really helpful to our patients also. I think this is interesting on our national statistics. I wanted to put up a couple of slides here just showing most frequent procedures that are in the U.S. hospitals. This is they actually have a research and quality on this that said that the average consumption, I thought, was of the red blood cells was 10 to 30,000 units per facility. I thought, wow, that's a lot. And nearly 14 million allogeneic red cell units transferred per year at a direct cost to these hospitals for over $3 billion. And that's only average of a unit of 225. And you know, most of us know that a unit of blood costs way more than that. And they're showing that 59% of these red blood cells transfusion were found inappropriate. Because you can see that most of these patients that we see are taken care of by more than just one primary physician. They're taken care of by multiple physicians in these hospitals, and most of them kind of just drop by and say, oh, they see the number of the H&H, and they say, well, why don't you give them 2 units of blood or 1 unit of blood? So it's kind of, they review the lab results and just kind of quickly draw orders for blood products. So healthcare costs are increasing more than ever. And of course, we need to be very diligent on doing this, making sure that we are giving it for the right reasons. Blood costs include more than just collecting of the products. If you do collect a unit of blood, they don't only have to store it, or not only collect it, but they have to store it. They have to do some testing, make sure it's safe. And then, you know, if there's any side effects that this patient might have after receiving it, it just increases a longer hospital stay. And this analogy with the iceberg has been shown over a couple of times this week too, but transfusions are compared to icebergs that's showing only 10% of their costs, but actually it's very much underestimated with their safety costs done to make this blood safe to administer. The National Summit on Overuse, I thought was interesting. Back in 2013, they identified 5 overused treatments. And remember when we used to go to the doctor and if we didn't come out with a prescription for some antibiotics or something, we thought, well, how am I ever going to get over this cold? They didn't give me any antibiotics. I kind of got shunned here. So, and that's also with blood transfusions too. That was one of the overused treatments. So with this case study statistics with Lepar, it said that 47% reduction in the odds of death and 50% decrease in total hospitalization costs. So if we would institute a blood management program, these would work to help our patients get better faster and reduce our patient costs and the hospital costs too. So if we could reduce the hospital stay, reduce hospital costs, and reduce our patients' costs, we could find another Trump, let's see, how would that be? Trump medical care instead of Obamacare. But if some of our case study stats also for coal showed that the implementation of a blood management program that first year, we could decrease our patient blood products by $500,000 that first year. So a take-home message here for you and for our hospitals also. So if you would help incorporate a team approach for blood management, you will help improve the patient outcomes, lower their risk, and reduce their cost. You do this with the best evidence-based outcomes, and have you be the champion. You can have a physician do this, but if you could help them do this, they seem to, maybe they don't have enough time or whatever, but have a perfusionist be the champion on this and get this directed and gone a little bit quicker too. And you can start your own blood management program. And you know what? You don't have to reinvent the wheel on this either to start your own blood management program. So if you need some help, there's ways with the SABM. They have wonderful blood management programs that you could help. AABB has one also, And Perfusion.com has their blood management program too that would be able to help you and is willing to assist. And of course, AmSECT. I have to put my AmSECT hat on too. So as Einstein stated, if nothing changes, if nothing changes. So thank you.